Cast is now starting. All attendees are in listen-only mode.
All right.
Good evening, everyone. My name's Dr. Al Rundio, and I am the clinical expert on the Providers Clinical Support System Medication-Assisted Treatment Grant that we have in collaboration with the American Academy of Addiction Psychiatry. The International Nurses Society on Addictions is who I represent. I'm a former president, and we have worked collaboratively with other organizations in educating healthcare providers and others about the opioid epidemic. I want to go over a few housekeeping chores before I introduce our speaker tonight. First, if you have any questions, we will be asking questions in the last 15 to 20 minutes of the presentation. Please type your question into the chat box only. Also, this week you will receive online an evaluation, which we encourage you to complete, and then you will receive the evaluation again 30 days later. And this is part that's required of the grant. This session is being recorded and will be available both on the International Nurses Society on Addictions website, as well as the American Academy of Addiction Psychiatry website. Tonight, it gives me great pleasure to introduce Dr. Alan Masri. I have the pleasure of working with him in an addiction treatment center where I practice at in Southern New Jersey, and I know he will also tell you more about himself as we progress. Next slide. Dr. Masri reports no conflicts of interest with this presentation. Next slide. And the overarching goal of the PCSS MAT grant is to train a diverse range of healthcare professionals in the safe and effective prescribing of opioid medications for the treatment of pain, as well as the treatment of substance use disorders, particularly opioid use disorders with medication-assisted treatments. Next slide. At the conclusion of this activity, the educational goals are that you will be able to describe the most common psychiatric conditions seen in patients with opioid substance use disorders, describe treatments that are utilized to treat these conditions, and discuss the challenges to treatment in this patient population. Next slide. And now I will turn it over to Dr. Masri, who will present this evening, and again, we will answer questions towards the end of the presentation.
Hi, good evening. My name is Dr. Masri. I'm a psychiatrist. I've been practicing psychiatry since 2007. I've done an addiction fellowship. I've treated dually diagnosed patients, severely mentally ill patients that suffer from addiction as well, due to my work at the state hospital. And I work with Dr. Rundio in the Recovery Care Centers of America, which is a multi-hospital center that treats people for their addictions. So I have a lot of experience. This is talking about opioid comorbid substance use disorder as well as opioid use. So I do have to talk a little bit about opioids. So opioid substance abuse disorders, a big problem with substance use disorders is opioid use. The reason that opioid use became such a big problem is the advent of pain medications that were so powerful that they overtook people's ability to stay sober and not misuse it. In the beginning, there was a use for pain medication. So what these slides show you is that there's another side to the pain medications, that they do help with other things. Obviously, the risks are outweighing the benefits, but people would use them for what they'd call headaches or moodiness. So it was used back in the 1800s. And in fact, heroin was created in order to help people with pain, and the word heroin comes from, they thought it was a hero medication for military people. So this one doctor had good intentions and created heroin as an alternative to morphine that he thought would be less addicting and would help those people that had severe military trauma and injuries. 1995 is when OxyContin was approved. Back then, until now, everybody was pushing what's called pain as the sixth symptom. So every patient we'd see, we talk about pain. And then as a doctor, when you prescribe OxyContin, or as a nurse working on a unit, when you give a patient oxycodone, right away they respond. The pain disappears, everybody pats themselves on the back, and they think they're doing a great job, not realizing at that time how devastating it could be. The U.S. opioid consumption in general, the U.S. consumes more than 80% of the global opioid pain pill production, even though it has less than 5% of the world population. That's amazing. I'm trying to get to the next slide. What happened? Okay. Here's what we know about opioid misuse. In 2016, 11.5 million people self-reported that they had personally misused prescription drugs. The most commonly reported reason that opioids were misused was to relieve physical pain. The misuse of opioids were obtained from a friend or relative, 53%, through prescriptions or stealing from a healthcare provider, 37%, or typically through another doctor. Drug dealer, less so. Now we'll go to drug use and mental illness. They often coexist. There is something called I guess you could call it the chicken or the egg. Is it substance-induced disorder, or is it mood disorder that caused substance use, or is it both? That's very difficult to tell. What I can say is that the DSM-5 and psychiatrists, what we look for is that somebody has a 4-week period at least without any drugs, and to see how they perform. If they have no mood symptoms, then most likely you can say that the substance use disorder caused the mood disorder. That's easier said than done. I mean, if it's a young kid that just started off with drug use, it's very hard to tell what the difference is, especially if it's attention deficit disorder and drug use, or if it's bipolar disorder and drug use. You'd have to ask about their family history. If they're older, you can ask what was their longest clean time, and during that period of time, ask their significant others how they were doing, and maybe that's a way. But nonetheless, there is a correlation between mental illness and drug use. There's another phenomenon where people are self-medicating. So in the PTSD population, alcoholism in the veterans was extremely significant. Back when there was the Vietnam War, for people that are in that age category, opioid use was extremely significant, but that was subsequent to the fact that they were exposed to it in the Vietnam location. When Afghan war occurred, again, opioid use skyrocketed in the military population because of the availability of heroin and opium in the Afghan region. So alcohol seems to be a big self-medicator. People that have social anxiety may drink a lot. People in college may drink a lot to try to fit in with their peers. When you have very bad depression and you can't sleep, elderly population have a tendency to increase their drinking to try to self-medicate themselves to sleep. They might not even realize that they're going into substance use, because when they were younger, they could drink 2 beers a day, not a big deal. When you're older, 1 beer a day is a big deal, 1 standard drink, I should say. The National Bureau of Economic Research reports there's a definite connection between mental illness and the use of active addictive substances. That people that have mental health are responsible for 38% of alcohol consumption, 44% of cocaine consumption, and 40% of cigarette consumption. So the majority of the cigarette consumption, so I'm sticking on cigarette consumption because we've done a great job of decreasing the amount of new cigarette users, but we haven't decreased it in the mental health population. So that could be a good clue for mental illness if they're a heavy cigarette smoker, especially at a younger age. In of itself, cigarette smoking is a good clue. If somebody's smoking cigarettes at age 12, that's a good clue that they're at extreme high risk for substance use. And think about it. Most parents can smell cigarettes on their kid. If your kid came into your house 12 years old or 13 or 14 and they smelled like cigarettes, you would take action. But if you were a household that has a lot of stress going on, or very poor parenting, or very poor peer supports, or no oversight, or a laissez-faire attitude, you might let your kids smoke cigarettes, which then would lead them to get to other drugs. So cigarette smoking at a young age is a big indicator. The connection between mental illness and substance abuse, again, I just talked about it, self-medication. It seems to be by far the most reason. From a neurobiological perspective, substance use can mess up the prefrontal cortex, orbital frontal cortex connection. So when you have impairment in the prefrontal cortex and the orbital frontal cortex, your impulsivity decreases. The lack of impulsivity can lead you to have some symptoms that would be suggestive of like a bipolar type illness. The other way around, when you have mental health issues, there's definitely a decrease in the orbital frontal cortex. The orbital frontal cortex plays a role with the stop-go phenomenon, so their ability to regulate themselves is decreased tremendously. The prefrontal cortex is an overseer of all this, and it helps slow things down. That's usually underdeveloped in people that have mental illness. There's an association between an overdrive, for example, in people that have PTSD, and in the areas of the amygdala, which alcohol can numb. So there is some neurobiological basis, and I guess all of it can go under the umbrella of self-medication. Dual diagnosis, that's the terminology. So there's terminology called dual diagnosis, or chemically ill, mentally ill chemical abuser, MICA. That's another diagnostic statement that can be used to describe people that suffer from both substance use and mental illness. It's as much as 45% of people with addiction in general have a co-occurring disorder. Bipolar, by and far, is the greatest co-occurring disorder to occur with mental illness. Excluding cigarettes, schizophrenia is the one that has the highest amount of cigarette smoking. Co-occurring mental health conditions and substance use disorders affect about 9 million Americans each year. There are many psychiatric conditions that occur with substance abuse, and I'm going to go into that. When we're talking about opioid use in particular, 19% of Americans with mental health issues abuse prescription opioids, whereas only 5% of people without mental health. So in the case of opioid use, you have almost a 5-time greater likelihood of developing opioid use if you have an underlying mental health issue. When talking about opioid use in general, and not cigarettes or alcohol, there are some common psychiatric illnesses that occur with it. Depression, bipolar, of course, number one, PTSD as well. I'm going to skip this slide. Depression is correlated with opioid use, and people will tell you, when I take my Suboxone, or when I take my Percocets, or when I take my opioids, I feel energized. What they're saying, I imagine, is I feel less depressed. So there is a correlation between improvement in depression and opioids. There was a big study in Israel showing that low-dose Suboxone, or something like Suboxone, in other words, low-dose opioid partial agonist, around 2 milligrams of Suboxone, can help depression. And in fact, there was a company that was trying to get FDA approval for it, but in this current age, there's no way you're going to get the FDA to approve a new opioid medication, even if it's for depression, and even if it was a partial agonist. Nonetheless, it appears that people that have depression, and the type of depression where they're not motivated, they don't want to do stuff, they stay in their bed a lot, they have poor self-care, seems to respond to opioids. Despite the fact that we know so much about opioids, and the fact that since 1995 we realized what a big deal it is, in 2015, since 1999 to 2015, it's quadrupled the number of prescriptions for opioids in the United States. So the problem's still here. It's not going anywhere. Now, the other side of the equation is that there is some news that's very saddening, which is that when I first talked about it, 53% of people got involved with opioid misuse because they took their friends or they got pills, and then 37% because they were prescribed. Right now, what's happening is that new kids, new opioid users are being exposed to fentanyl. So, and fentanyl is about 50% the price of heroin, which is about 10%, which is 10 times less than the price of Percocets. So drug dealers are very much pushing fentanyl, and fentanyl is very potent, much more potent than oxycodone and heroin. And this is why so many people are dying. Now let's talk about schizophrenia. So the purpose of this slide, again, is the correlation between substance use and, opioid use and comorbid mental illness. So I'm focusing on that. But again, schizophrenia has a high correlation of cigarette smoking, and it's very important that we try to help them with that. Nonetheless, schizophrenia and opioid use. Schizophrenia is a brain disorder. It affects 1.1% of the American population, just say 1% of the American population. That's about 2 million adults. People with schizophrenia may have significant response to various social situations that appear. So diagnostically, what happens in schizophrenia is your ability to understand your surroundings is impaired. So your ability to filter out certain things is gone, especially your auditory evoked potential. So what does that mean? That means I'm sitting and I'm talking to you, and in the background, somebody else is talking. Unfortunately, if in the background that person says your name, you're going to, if you have schizophrenia, you're going to put it into your head, convert it into a voice, and then say, somebody's talking about me, because you have an inability to filter it because of the lack of a pruning. So you have all these external filters that are very difficult to occur. You have dopamine, an excessive surge of dopamine, which then causes a decreased surge in dopamine in the pleasure areas. So at one side, you have too many emotions and too much dopamine. You are taking in too much information from your environment. On the other side, you have a disparity of dopamine in some of the pleasure centers. So when you take drugs, you're going to feel good, whereas before you didn't feel good. Schizophrenia by itself increases your risk of depression and suicidality. So people that have schizophrenia, when they do drugs, it helps them. Also, it may decrease their overall ability to decrease the voices by just numbing them and nodding them off. In particular, opioids can do that. And alcohol as well. Alcohol is a big thing in schizophrenia. So there is a correlation between schizophrenia and a much greater risk of using drugs. There is a correlation between schizophrenia and a much greater risk of using opioids, although they're more likely to use marijuana. They're more likely to do cigarettes or alcohol. Going to marijuana, we're finding out, and probably in 5 years from now, marijuana is composed of tetrahydrocannabinoid and then cannabinoid receptors, right? Cannabinoid is good. The tetrahydro is the one that gets you high. Cannabinoid receptors actually can help schizophrenia. So in the future, you might see cannabinoid receptors being used in schizophrenia. But coming back to this, let's talk about treatment. So the best treatment we found is the fact that from a medication-wise is clozaril and Zyprexa. So clozaril and Zyprexa are the best treatment. Why clozaril and Zyprexa? So what is Zyprexa? Zyprexa, so the company that made Zyprexa just took clozaril and copied it, and they changed a couple of chains. So a lot of the antipsychotics are just taking other ones and changing it. So they took clozaril, they took off a few of the carbon chains, and now you got Zyprexa. So that's why Zyprexa and clozaril, because they're extremely similar. Also, they decrease to a greater extent the auditory evoked potential. So as I was discussing before, if you have schizophrenia, you can't filter out external noises. As a result of not being able to filter out external noises, you can't differentiate. You hear things and see things and stuff like that. Clozaril and Zyprexa help with that. They're far and away the best in that population. The problem is if you take Clozaril and you smoke cigarettes, your Clozaril levels go down. So cigarettes is the thing you have to look for. Also remember, people that do schizophrenia don't want to get treated, so they're less likely to get treated. They get into more legal problems, so their total prognosis is worse. Let's talk about depression and opioids. Is it depression that leads to opioid use, or is it opioid use that leads to depression? So we don't really know. So there is a study from St. Louis that found that 10% of over 10,000 patients prescribed opioids developed depression after using the medication. None had a prior diagnosis of depression. In one study, persons on chronic opioid therapy with moderate and severe depression were found to be more likely to misuse it. So it seems that opioid use in this one study can cause depression. I know that in Israel and other places, they did studies that show that low dose of opioids improve people's depression. I know that patients tell me, I take an opioid and I feel great. Personally, if I take an opioid pill, I'm sleeping and I'm constipated and I don't like it, but I take it if I have pain. But as soon as I don't need to take it, I stop taking it. When you're addicted, you just can't stop taking it. So I think that there's a correlation between the two of them. I think that people that take opioids, my personal opinion, may have depression because of their socioeconomic situation, but not really have depression per se. But I do believe that people that are depressed will be more likely to be exposed to opioids and more likely to misuse it. So let's see, let's skip. People with depression misuse painkillers twice the rate of non-depressed individuals. And the take home from this slide is if you have a mental health issue and it's before your drug use, you're much, much more likely to abuse any drugs, opioids as well. How do you treat depression with co-occurring? It's a very difficult challenge. So antidepressants are not going to hurt the course of treatment for opioid use disorder. So I would be more aggressive. I would use medication-assisted treatment coupled with an antidepressant. I may consider them as treatment resistant and add them on 2 antidepressants, or I might add them on Prestique, which is a serotonin norepinephrine reuptake inhibitor. Prestique is good in the sense that it has less drug-drug interactions. It doesn't have a shorter half-life. Cymbalta is good in the sense that it helps with pain, but Cymbalta is a serotonin norepinephrine reuptake inhibitor, but it does have more drug-drug interaction. Sorry. But don't forget to do the therapies, like one-on-one therapy, group therapy. So another way to treat depression is getting them with a group of people that are supportive. If you can get people happy and high on life, so to speak, that can help depression in of itself. So bipolar disorder, far and away, bipolar disorder is the biggest risk factor for developing an opioid use disorder from the mental health issues. After that, it's PTSD and depression. But far and away, bipolar is a really, really big one. And the reason bipolar is a big one is because they share neurobiological similarities. They both have problems with the orbital cortex. They have problems with the ability of the prefrontal cortex to inhibit impulses. They have problems with affect regulation, and they have problems with the ability to delay gratification. Both of those things occur in manic bipolar people and substance users. 56% of individuals with bipolar disorder, according to the national study, has experienced drug or alcohol drug addiction in their lifetime. 46% of them were alcohol, 41% were addicted to drugs. Alcohol is the most commonly abused substance among bipolar people. The rationale is that it's available. How is bipolar and addiction related? I already talked about that. There are symptoms of bipolar disorder that can lead people to want to use drugs to shut things off. If they have trouble sleeping, if they're too irritable, if they're feeling themselves anxious, maybe that's where the drinking comes in. You have to treat them both together, but you have to make sure you do a good diagnosis because they mimic each other. It's very difficult to differentiate between substance-induced mood disorder and bipolar disorder with co-occurring substance use. And the way you differentiate it is the longest clean time, how were they like, talk to family members, get a family history. If everybody in the family has bipolar disorder, just might as well say they have bipolar disorder. The problem with substance use and bipolar disorder is that bipolar disorder, it starts earlier. So if you use substance and you have a predisposition to bipolar disorder, you're going to get it earlier. It's much harder to treat. It's associated with mixed symptoms as opposed to classical manic depressive symptoms. It's associated with a greater risk of suicidality. It's associated with a greater risk of poor medication adherence. So it's pretty complicated when you add those two together. What do you do for treatment? Lithium for bipolar 1 is very good. It does seem to help with opioid use, but it's a tricky medication. It seems to help with bipolar type 2 as well. So it's not a bad medication. Valproic acid is pretty good for people that have problems with alcohol. The reason valproic acid is good is because sometimes it prevents the adverse effects of not being on alcohol. So when you take alcohol out of somebody that's a heavy alcohol user, you're going to have shakiness, tremors, all these weird things. Depakote prevents that. It's not as good as preventing relapse into other substances. It causes weight gain. A lot of people relapse into cocaine because they've gained weight. So there's a lot of women that gain weight because they stop doing drugs. You put them on Depakote and they gain a lot of weight, and all of a sudden they're doing drugs just because they want to lose weight, and they say they're going to do it for a little bit. So I don't know if it's helpful for the cocaine abusing population or the opioid abusing population. Tegretol seems to be good for, there's some case reports that suggest that Tegretol seems to be good for people that abuse cocaine. The problem with Tegretol is when you have it in your body too long, it makes other medications blood levels decrease. It causes bone marrow suppression. It can cause its own level to decrease. So if you use 100 of Tegretol, all of a sudden you're going to need a lot higher than that. The other issue with Tegretol is it's not good for pregnant females. Depakote, of course, as well. So Depakote is very bad for somebody that's pregnant or wants to get pregnant. It's actually worse than lithium. So although lithium causes problems with people that want to get pregnant, it's detectable, it's preventable, it's not as common. Whereas Depakote can really screw up the baby. Additionally, Depakote can occur like 2 weeks. So if somebody's on Depakote and they got pregnant and they didn't know for 2 or 3 weeks, maybe the damage is already done. It causes neural tubular deficits. Whereas lithium is later on in the pregnancy. But going back to other medications, Topamax has shown a lot of case reports for helping alcohol use. Topamax has shown to be helpful for cocaine use. Topamax, unfortunately, has not been shown to be helpful for bipolar disorder. But people like it, and so it might be helpful. The problem with Topamax is it has this acronym called Dopamax or Dopimax or Stupid Max, because of the fact that it maximizes cognitive dulling. So you forget things. You could literally have your keys in your hand and you're like, where did I put my keys? That's what Topamax does. Most of the Topamax studies were indirect because it was an amazing medication for migraines, and a lot of patients decreased their drug use with Topamax when they were taking it for migraine, but they also had the complaint about forgetfulness. By the way, Topamax helps with weight loss. It helps substantially for some subset of population. There's a medication called Kysema, which is basically Topamax combined with Adipex. So it does help for that. So if you have patients that are worried about weight, that can help. I don't use it that much, but I might. The other thing about Topamax is it causes renal stones. So you have to be careful of that. PTSD, so opioid users, bipolar, PTSD, those are the things that are more likely to have opioid use, and then depression. Remember, bipolar mostly presents as depressed, so depression is there either way. PTSD is a condition where people I mean, I know I don't have to describe it to you, but essentially the way to conceptualize PTSD is depression with anxiety with nightmares, right? So people that have PTSD can get very tense or hypervigilant, in other words, anxious in certain situations, and they can get down and not motivated and feel emotional numbing, which is a symptom of PTSD. And then they have the nightmares, the flashbacks. That's the easy one. Sometimes they don't have the flashbacks or nightmares, but they have the other stuff. But in any event, PTSD greatly increases your likelihood. So in the regular population, 3.4% of people have PTSD. Obviously, people that are in the military have a greater likelihood of having PTSD. Mentally ill people have a greater likelihood of developing PTSD. Not only does mental illness increase your predisposition to PTSD, but usually the socioeconomic issues associated with mental illness increases your likelihood of being traumatized. Mental illness increases your use of drugs, which in of itself increases your use of having PTSD. Does PTSD make you a drug user? Yes, it does. If you have PTSD prior to the drug use, a lot of people will develop PTSD as a result of the lifestyle associated with their drug use. So prostitution, getting a gun put in your face because you gave the person the wrong money, you name it. You can get into it, but I'm sure you can figure it out. What is PTSD? We experience the trauma, avoiding emotional numbness, depression-like things, hyperarousal, irritability, anger, extreme anxiety. Alcohol use was a big deal for PTSD until opioids became a thing. Then opioids far and away exceeded alcohol misuse in people that have PTSD. So how do you treat people that have PTSD? So alpha adrenergic medications such as clonidine or prazosin. So what is prazosin? Prazosin is mini-press. It's used in the military. Prazosin works on the alpha-1 adrenergic antagonist. So that means that it stops alpha-1 from working. And when you stop alpha-1, you decrease sympathetic nervous system decreases. And that's one way it works. It also vasodilates vessels. It prevents prostate cancer, whatever. So it helps in that sense. When you have clonidine, clonidine is an alpha-2 agonist. When you turn on alpha-2, you turn off sympathetic nervous system. So when you turn on alpha-2, you turn off sympathetic. When you turn off alpha-1, you turn off sympathetic. So one of them works by turning off alpha-1, that's prazosin. The other one works by turning on alpha-2. But they both work on sympathetic, decreasing sympathetic drive in different ways. So clonidine has been shown to help from withdrawals from opioid use. Has it been shown to be helpful in PTSD? Not really. To some extent, it helps for the emotionality. So if you have those patients that have anxiety, low dose clonidine given 2 or 3 times a day is good. That might be a thing. If they have problems sleeping, if Remeron didn't work, if trazodone didn't work, then you might want to try clonidine. I mean, everybody responds to Seroquel. There's been a lot of studies about Seroquel and PTSD. There's positive results with that. The problem is that my experience with Seroquel is that the patients abuse it, and I find myself just giving it to them. I don't know what it is about Seroquel, and maybe the nickname on the street is Quell. Maybe it quells them down and gives them that false numbing that they like. But any event, that's how you can treat PTSD. What is the best treatment for dual diagnosis in general? Actually, let me see something here. In general, you want to take a parallel approach. And what does the parallel approach mean is that means you want to start their psychiatric treatment in the same time you do their treatment of their drug addiction. You want to have therapists that are aware of people that have drug addiction and drug use and mental illness. You want to normalize it as much as possible to remove the stigma of both the fact that they have a mental illness and drug use and the fact that they're on medications. Because in the AA or NA population, there's a lot of stigmatization of people that do any drugs, including prescribed medications, appropriately prescribed medications, and have AA attendance. So you want to normalize that. You want to get the family involved. And nowadays, it's not as hard as it was. There's a lot of, everywhere you look, there's a Silver Living House, there's a treatment center being opened up. So there are more treatment modalities. If you're a family member, you definitely have to get involved with family groups and know what's what, know how to set limits, but at the same time, not abandon your kids. Understand that they can't process emotions, especially people that do cocaine or opioids. They can't process emotions. So when you're screaming at them, why did you take all that money? Your kid, like if you have a kid that has a kid and she's using money instead of paying for her kid, they don't get it. They won't get it. There's no ability for them to have feelings in their emotions. And if they have depression or PTSD, it'll just be a re-experiencing of the trauma or triggering of their depression. So as family members, you have to try to figure out a way to communicate with your loved one without triggering their addiction, but at the same time without kissing their butt. And it's a little bit complicated, but there's ways to do it. Again, there's Silver Living Houses all over the place, so you can always put your kid there. But you also, if you're a family member, should be aware to tell, hey, look, we have a family history of mental illness. If you're a nurse, obviously nurses, if you're treating patients in a medical unit that's not related to a psychiatric unit, you might want to point it out. Why don't we get a psychiatric consult on this patient? You shouldn't do it in the beginning when they're getting detox, because when they're getting detox, the patients want every medication that they can get their hands on. But later on, if you're the one that did the psychosocial intake, or if you did the intake for the patient and you have a feeling that there's some mental health, you might want to ask for that. Okay. So what are the treatment modalities for substance use in general? Is detoxification, then inpatient rehabilitation, then psychotherapy, and then outpatient. There's different level of cares. Remember that there's a stigma associated, was a stigma, it's getting less associated in Alcoholics Anonymous and the use of any prescribed medication. But there are special groups that for people that suffer from dual diagnosis, or another name is mentally ill, chemical abusing, MICA. I went through these slides. Let me see. Okay, so I went a little bit faster. So we have a little bit more than 20 minutes, but that gives me a lot of time to take your questions. Al,
can you go to the next? Yep, can you go to the next slide? Just click the next one on. I think it's questions.
Okay. Questions.
There we go.
All right. Does anybody have questions?
Don't forget to type your question into the chat box, and then we'll read it and we'll respond to the question. We have about 20 minutes for questions. Usually we get a ton of questions, so we wanted to leave enough time for questions and answers.
All right. I don't see any questions.
No, I don't either. Well, I have a question.
Sure.
Get it rolling. As you know, we've been using for a while, providers have been using Neurontin a lot. And of course, what I see with a lot of patients coming in with substance use disorders, some of these patients are really on very large doses of Neurontin, like 2,400 milligrams, 3,600 milligrams a day. And of course, they want their Neurontin, but of course, now we know there's a correlation with opioid dependency and Neurontin. So I just wanted your thoughts about the use of Neurontin.
Right. So Neurontin is the use of Neurontin, also known as gabapentin, Lyrica, also known as pregabapentin, in the use of people that have anxiety and opioid use, is probably going to not be a good choice. What they found out in the state of New Jersey, they actually made it that if you prescribe Neurontin, it's going to show up on the prescription monitoring program, is that the patients have a tendency to abuse Neurontin. the reason that they abuse Neurontin is it causes that dulling effect that they like. So if you take 600 or 800 milligrams of Neurontin in one shot, you can get a very good cognitive dull effect, which mimics the doping effect that opioids do. If you're doing Neurontin 300 milligrams 3 times a day, it's not that bad. Now, if you have somebody that's a benzodiazepine abuser or alcohol abuser, then it's a really risk-benefit. So if you can get them away from their benzodiazepines by using Neurontin, you're better off. And as far as alcohol is concerned, there's a lot of studies in Europe that show a correlation between the use of Neurontin and the prevention of relapse with alcohol. But that's only for alcohol-only abuser. So going to this population of opioid users, I would stay away from Neurontin as much as possible.
Okay, and then when they come in and say they're on like 3,600 milligrams a day, I would think that too you'd probably want to wean or taper them down as opposed to abruptly stopping it.
Right. The other negative about Neurontin or Lyrica is that you can't taper down with something else. So you can't replace Neurontin with Depakote. You could do that, for example, for benzos. Like if you want to taper somebody from benzos, you can put them on a relatively high dose Depakote and then quickly taper them off of a benzo. You can't do that with Neurontin. You have to replace Neurontin with Neurontin. So you'd use a tapering schedule over 3 weeks, decreasing by about 20% per week, maybe a little bit quicker than that, because obviously if it's 20%, it would be 5 weeks, but a little bit quicker than that. You can jump from 300 3 times a day to nothing. Should not be a problem. If it is a problem, you can give them 100 twice a day and then go to nothing. The other thing is if a patient says that I'm on Neurontin because I have neuropathies, you'd like to ask the patient, can I get the EMG studies? So you want to get the you want to see if there was a diagnosis, an actual diagnosis of neuropathies, which would be done through the use of electromagnetic myograph, where they stick needles in their muscles.
Right. Yeah, and
Wow. Yeah.
the patients, are treatment savvy and they tell you they have a neuropathic condition and that's why they're on it, but you really don't know if that's why they're on it,
Yeah, that's exactly correct. And I'm surprised there's no questions. Was I too fast?
There are. I think the attendees couldn't use the chat option. I've got a bunch. If Al, you might be able to see them under the questions tab too, but I'll just start reading the first few out, and Al, you can stop me if we run out of time. First one's a short one. Stephen asked, "Is there any treatment for marijuana?"
Yeah, great question. No, there's no medication for the treatment of marijuana, and you can't use prescription pill marijuana called damn it, I just blanked out on the name. Anyways, no. However, there's cognitive behavioral therapy, so it's very much similar to the treatment of cocaine, which is cognitive behavioral therapy, harm reduction. It's extremely difficult to treat severe marijuana dependence. In my opinion, it's more difficult than any of the other ones.
Okay. Next is, could you please talk more about I think it's pathophies regarding the prefrontal cortex in patients with bipolar? Yes.
So so what happens is in bipolar disorder, there's a problem with executive functioning, to say simply. So executive functioning is composed of different parts of the brain, and executive functioning requires you to have ability to have good memory, ability to predict the consequences of your action, ability to control your impulses, and ability to delay gratification. The areas of the brain that we believe work on those things are the prefrontal cortex, which is the dorsolateral prefrontal cortex, okay? And this is what it does is it helps you with delayed response test, which is your ability to delay things and to think before you take action. The orbital frontal cortex is obviously the area of the brain that takes in information and makes you have a decision quickly, right? And that's the And when you have people that have bipolar disorder, they have deficits in their orbitofrontal cortex, which is they're taking in information too quickly without taking in it fully. So they're not processing information fully. And their prefrontal cortex is not fully developed, so they're not having the mature part of the brain saying, hey, slow down, think about this. Remember the last time you did this, something bad happened, predicting the future. You also have problems with their memory, so they can't seem to remember emotional things. And in addiction, what happens when you do addiction, and a normal person that becomes addicted over time, is you destroy the ability of the prefrontal cortex to inhibit the orbitofrontal cortex's impulses, as well as the fact that you drive the person to just pleasure seeking and harm avoidance, right? So the ventral tegmental area, and in addiction, we're all about seeking pleasure and avoiding harm. That's it. Seeking pleasure is getting high, avoiding harm is avoiding withdrawal. That's it. We're at an animal level. When you're an adult without addiction, you have the thing about harm avoidance, pleasure seeking and harm avoidance, but pleasure could be having a good time with your kids. It could be regular things. That memory and that higher level of pleasure is disrupted. Additionally, when you have bipolar, that ability to control your impulses is disrupted. So you have, on one hand, the inability to understand things as normal, healthy life things as pleasurable, and on the other hand, inability to control impulses. So they both together, substance use and bipolar, have a worsening. So now all you think about is having pleasure. You can't stop yourself from doing stuff, and you're very unable to remember consequences or future consequences of your stuff. I hope you understood what I said by that.
Okay, next is, would you please teach the pathophysiology of PTSD and the sympathetic nervous system again at a little more depth? That might be too much to do now, but if you can,
Well, all right. So PTSD is a condition that is resulting in hyperarousal because you've been in the fight or flight mode. So our bodies have the parasympathetic and sympathetic systems. The parasympathetic is related to regulation of heart rate and GI stuff and keeping you on a normal even keel. The sympathetic is in the fight or flight mode. That's for helping you to run away, to fight. So when you have PTSD, that there's an overdrive in the stimulation of the sympathetic nervous system. That's indirectly done due to the situation that's happening at the level of the amygdala as well as the hippocampus. So the amygdala controls emotions, emotional memory. The hippocampus regulates memories in general, especially learning memories. So you have a problem with those two, which then triggers your amygdala to so to speak, so to trigger sympathetic to be in overdrive. So when you're giving somebody something that works on lowering the sympathetic overdrive, you're decreasing their hyperarousal, their irritability. You're also decreasing to some extent their emotional numbness because the hypothalamus is being slowed down. You're decreasing that. You're allowing them to take in more things. There's some evidence to suggest that if you give beta blockers during a session in which a person is hyperaroused, you can help attenuate the link between the memory and the hyperarousal. In other words, the emotional memory and triggering the amygdala to turn on. So that's essentially what's happening in PTSD, and that's why those medications seem to help.
Okay. Next is, this one says, for general practitioners, do you have a favorite antidepressant, anti-anxiety med to start a dual DX patient on when presenting with anxiety and depression?
Yeah, so I like to start off with Zoloft if they have PTSD, because Zoloft seems to have the most studies, and then I'd add Remeron at bedtime if it's sleep. I take a chance and I try Boost Bar. Boost Bar, when it works amazingly. Usually works better at higher doses, 30 milligrams 3 times a day, which is a very high dose. Normally 60 milligrams is the max, but I'd like to go, so 15 milligrams 3 times a day, 20 milligrams 3 times a day at a Boost Bar. I try either Prozac or Zoloft. Prozac because it stays in your body for a long period of time. Zoloft because it's a little bit more potent than Prozac. If those don't work and they have anxiety, then I try the serotonin, norepinephrine, reuptake inhibitors. Sometimes I start that off right away. My favorite is Prestique. We just have 3 of them. So we have Cymbalta, and we have Effexor, Prestique. Effexor and Prestique are the same. Effexor is Prestique is just an isomer of Effexor, meaning that it doesn't have as many side effects. But in a head-to-head trial, there's no difference between Effexor and Prestique from a functioning standpoint. The difference is in side effects. Then you have the other one, which is kind of brand new, Fadzima, but that's more of a norepinephrine serotonin as opposed to serotonin norepinephrine. So I haven't used Fadzima too much, but I do use Prestique. And the reason I like Prestique is it doesn't have as many drug-drug interactions as Cymbalta. The problem with Prestique is insurance companies don't pay for it, so you might end up having to use Cymbalta or Effexor. And again, Prestique is simple dosing. It's 50 or 100 milligrams, whereas Effexor is 37.5 and 75 and 125, 150, whatever. Cymbalta is like 60 milligrams twice a day, or 60 milligrams. So I start off with Prozac or Zoloft. I might add Buspar, and if needed, Remeron. If Prozac or Zoloft doesn't work, then I go to Prestique. If they've been tried on antidepressants before, I go to Prestique. I still add Buspar. Why? Because there's no side effects associated with Buspar. If it works, great. If it doesn't work, not a big deal. I use higher doses of Buspar. Other times, I may consider the use of clonidine at bedtime, or clonidine 0.1 twice a day. So those are the combinations I use for anxiety in people that have depression. Obviously, you can't use any of those things in bipolar. Well, you can't use antidepressants in bipolar disorder.
Okay. What practical or evidence-based mental health disorder screening tools would you recommend when doing an initial evaluation in primary care setting with substance use disorder?
So that's a very good question. So I'm blanking out. So there's the bedside substance use questionnaire, which is the CAGE questionnaire, and it can be modified to be for addiction, and that's for adults. For adolescents, you want to use the what's it called? There's another one just for adolescents. But if you go to the SAMHSA website, SAMSHA, they will tell you what are the best screening tools. Because of my experience, I ask a lot of questions and I just know how to do it. But there are screening tools that are available. There are brief screening tools that are available. There's the MASS Michigan alcohol screening test. That seems to be a good one. The CAGE questionnaire, like I mentioned. The CRAFT, that's the one for kids, is the CRAFT questionnaire. For kids, because they don't have a lot of the symptoms of overuse of medication, you want to ask them about their friends. So the CRAFT questionnaire has, have you ever been in a car with somebody that does drugs? Do you do drugs to feel relaxed? Because with adolescents, they're not, their bodies, you're never going to have your body as physically perfect as you are from between 18 and 30. So you don't have too many side effects from drinking a lot. But what you do have is clues, which is, do you do it with friends too much? Do you do it to feel relaxed? So the correct answer is to look at SAMHSA, and they'll give you guidelines. The stuff I talked about is just to give you an idea.
Okay. Next, what if a patient can't stay off drugs long enough to be diagnosed with a psychiatric disorder?
Yeah, so that's a very good question, right? And the bottom line is that if you feel that their symptoms, and so the nurses know a lot when they're treating patients inpatient, because they see the patient all the time. I come in as a psychiatrist, hi, how you doing? I'm doing great. Or sitting on your chair and they're like, I'm super anxious. And then I ask the nurses and they're like, no, he's been joking around. So really, as a nurse, you should say, look, I'm watching this person and I can tell he's anxious all the time, or he's in his room all the time. He's sleeping nonstop. It's not just the withdrawal from the cocaine. It's like a little bit more. then that's when you just go ahead and treat the medication, treat them as if they have a dual diagnosis. Because that's the biggest tricky thing as a psychiatrist I have is I come in for a consult, I do 45-minute consult, 30-minute consult, two 30 minutes or 1 45-minute, and I don't get the big picture. Whereas the nurses have a better opportunity to give me that picture.
All right. Do you find very low dose trazodone and it says 12.5 milligrams QD/BID helpful with anxiety without significant side effects?
I've never used that. That's not a bad idea, because in addictions, you might want to try different things. So another take-home message is go ahead and try different things. As long as you're not using benzos or Neurontin, try it. So the answer is no, it shouldn't be, of course, you have to understand, make sure that they don't have bipolar, make sure that they don't have, explain to them the risk of priapism, which I don't believe is dose related. But having said that, it might work. Serotonin was an amazing medication for people that have depression and alcoholism. Serotonin and trazodone are very similar. The only problem is serotonin causes liver failure. So there's something called belazidone, which is very similar to what you're talking about, which is a combination of trazodone and something else. So you might want to try belazidone instead of trazodone, low dose trazodone, but nonetheless, that's not a bad idea. I might try it myself.
Okay.
On a patient. So I try it.
All right. Best technique for treating patients on Suboxone with depression and anxiety.
So the real technique is to try to get them involved with a therapist to make sure that they have the good support systems in place and to go ahead and proactively treat their depression and anxiety. The problem is that a lot of the patients are going to say to you that nothing works except for benzodiazepine. And you have to go within your comfort level. From an overall statement, you should not give people that have anxiety benzodiazepines if they're on Suboxone. However, there are cases where it could be done, but that should be done by a trained psychiatrist like myself or somebody or a practitioner that's been doing it for a long period of time. So the best treatment is to do things such as Buspar, such as an antidepressant, make sure that they're having the therapy and talk about their environmental, what exactly is their anxiety? Is it related to the fact that they can't pay their bills, that they have an abusive boyfriend or girlfriend, or is their anxiety really anxiety and they're functioning, they're a teacher, they had drug use history, not on Suboxone, but they still get anxious all the time? Then you might want to try an antidepressant, like I said.
Okay. Patient with rheumatoid arthritis with chronic pain/depression. What is the ideal Suboxone dose and antidepressant?
Cymbalta, provided that there's no drug-drug interactions with the rheumatoid medication. I would try Suboxone in congruence with the new, there's non-steroidals, there's new non-steroidals out there, and there's new COX inhibitors out there. So there's new medication for rheumatoid arthritis that seems to be very good. If not Cymbalta, some indication for Benzema, although that's better for chronic fatigue. So Cymbalta or Benzema. If none of those two are working, Alevil sometimes can work, but you have to understand the tricyclic problems that are associated with Alevil, such as cardiac issues. So Benzema, Cymbalta, Benzema, Alevil, Suboxone, as far as the dose is concerned, it's very dependent upon the person, but the take-home message is take it more than one time a day. So maybe you might have to use as much as 24 milligrams, but that's in only cases where everything failed. All the newer medications for rheumatoid arthritis failed. It's the split dosing. So if they take it more frequently, it helps pain better. So it's not as much the amount that they take, but the frequency they take it. So maybe 4 times a day instead of 2 times a day, or 3 times.
Okay. There's quite a few more questions here, Al. It's right at 7 o'clock. Do you want me to ask a couple more, or I've saved all the questions?
Yeah, we could go for a couple more.
Okay, you okay with that, Alan?
Yeah, of course, my pleasure.
Okay, next question is any reports of patients abusing clonidine? Clonidine.
Yes, but not as much. There is a website called the Vault of Erwitz. There's another website, I just can't remember, that talks about how you can abuse the clonidine. So yeah, clonidine can be abused, but not that much because the drop in blood pressure can cause rebound headaches. So it's not that abused, but it can be. Almost any medication can be abused. Wellbutrin is very much abused in the addicted population, although it's one of my favorite antidepressants to use in non-anxious people.
Okay. One slide mentioned that patients with dual diagnosis bipolar and substance abuse received treatments that countered each other. I was wondering if you had an example.
Yeah, so if you have somebody that's bipolar substance use, and one of the things is in bipolar disorder, for severe agitation, benzodiazepines can be used at level 3, meaning they're on a mood stabilizer, but they're still agitated and anxious. Benzodiazepine can help the mood disorder as well as it. So that would be something you might not want to give to somebody who's a substance abuser. The other thing is, I mean, primarily that's the only question. That's about it.
Okay. What do you find helps with treatment of meth use?
Yeah, another great question. So the drug users, the Mexican drug users, which comes from Mexico, but anyway, the Mexico drug users were the biggest suppliers of drugs in the United States. They were switching with the war on opioids. They were trying to introduce methamphetamine and to the Northeast. I don't know how it is. I know it's worse in the West Coast. And so that was the question we were asking ourselves: is what can we do to treat that? And so apparently Topamax can do it. Maybe I haven't had success with it. Naltrexone, disulfiram, antabuse, Chantec. So there's so many different things that seem to be bizarre that help baclofen. So the right answer is no. Some people do low dose Adderall, although that kind of seems stupid. Strattera does not help with methamphetamine use unless they have an underlying ADHD. So we don't know yet. It's usually the therapies such as CBT, contingent management, harm reduction. So contingent management means for XYZ number of negative urine, you get something. So what happens is that there's a strong behavioral, there's a physiological addiction, but there's a strong psychological addiction with methamphetamine. And so to approach that psychological addiction, you want to use behavioral techniques such as contingency management.
Okay. What is the connection with smoking and schizophrenia?
So the connection between smoking and schizophrenia is that it inhibits the nicotine, it does stimulate the nicotine receptors, which then increases cognitive effects. So it's alleged that when you smoke a lot of cigarettes, you improve your thinking. There's also the side effect of cigarettes with Zyprexa is that it decreases the amount. So when you're taking cigarettes, you're decreasing the amount of Zyprexa, so you're decreasing the side effects. So also, when you smoke cigarettes, you're decreasing your appetite. If you smoke a lot of cigarettes in the beginning years, you lose weight. And if you stop smoking cigarettes, you gain weight. So it could be the correlation between cigarette smoking and schizophrenia is because of the fact that they are on medications and it makes them less side effects and makes them lose weight. It could be that when they're in schizophrenia, it calms their brain by enhancing the cognitive function so that the other part of their brain can override their voices and things. So like maybe they're hearing voices, but they can shut it down because their cognitive function is enhanced by nicotine. Unfortunately, Namenda didn't really help, which had some nicotine receptors, but there was some indication that Chantec, again, could help. Who knows? I hope that answered your question. Also, when they smoke weird. They suck in the cigarette really deep. So they take in, instead of 2 milligrams per puff, they take in like 4 milligrams of nicotine into their lungs. They smoke different from regular people.
Okay. This one I think has a typo, so I'll read what I think it's supposed to ask. What is the best RX for meth addicts?
Right. Topamax, supposedly, disulfiram in some studies. Unfortunately, as of now, nothing. But those are the case reports. So I'm just talking about case reports. Disulfiram, Topamax, baclofen. Unfortunately, there's still nothing yet.
Okay. Is there an advantage of using Librium over other medications during detox for patients in a correctional setting?
Yeah, the Librium is used because it doesn't go through the liver. That's the Sterax. No, the Librium is because of its half-life and its potency. So it's intermediate and potent, and it lasts long but not too long, so it's easy to manage and taper. That's why Librium has an advantage. It doesn't get you as high as Valium, diazepam, or Klonopin. I mean, Valium, Klonopin, or Xanax.
Okay, what are your thoughts on a client that has an SUD and is also diagnosed with ODD?
Right. So if you're saying ODD as opposed to OCD, ODD is oppositional defiance disorder. Oppositional defiance disorder, maybe there's a role in mood stabilizers, or some studies talk about naltrexone. So possibly naltrexone or mood stabilizers, but really it's a lot of behavioral management and parenting intervention. Because oppositional defiance disorder, as I understand it, has to be in children. If you're talking about OCD, obsessive compulsive disorder, then it's high dose SSRIs above normal, like 200 milligrams of Zoloft or higher. Tricyclics have. So basically, you go by the treatment algorithm for OCD in parallel to the diabetic stimulation, and a lot of new studies show that it works. So if we're talking about
Did we lose him?
now, going back to ODD, if we're talking about
Yeah, he's kind of breaking out.
Yeah.
But again, like I said, I've saved all these questions, so we can send them to him to be answered.
Okay.
All right. Yeah, thank you.
Okay.
Sorry, my headset died.
Next question.
Is that it? Oh, go ahead.
Oh, sorry. Okay, do you have any recommendations for making a bipolar 2 diagnosis in substance abuse patients? I have a difficult time identifying hypomaniac symptoms in my Suboxone patients. What is the range of hypomanic, I think it's hypomanic symptoms that you see in your patients? Sorry if I botched the term.
No, that's a good question. It seems to me that I have the same problem, right? I have a lot of patients that have irritability, a little bit of impulsivity, hyperactivity, sleep problems, and so I'm wondering if this is hypomania or not. So the DSM-5 has a new diagnosis, which is mixed, meaning you can have depression with hypomanic features. So I'm not adverse to doing antidepressants in people that might be having hypomania. If their behaviors get worse and the family members say it gets worse, then we know that it's definitely bipolar type 2. The other thing that could work is using Lamictal. It just takes a while before Lamictal kicks in, and you have to go slowly, but Lamictal might be a good choice. In order to officially diagnose hypomania, there's no really good scales because the ones that are out there are for bipolar. There is something called the life narrative scale, where you try to get a life story of the patient, and that can sort of give you the idea if there's hypomania, and that's available on the internet. I guess the clues would be their sleeping pattern and their interactions with their others, because they're going to tell you, well, I'm up and down, I'm up and down. And you have to differentiate, are you up, meaning higher than depressed, or are you just depressed and not depressed? In other words, are you dysthymia with depression, or are you truly hypomanic? So that's why, like I said, I'm not adverse to using antidepressants or Lamictal or Abilify. Abilify is pretty good, 2 milligrams, 5 milligrams. So I guess I would do antidepressant with Abilify just to hedge your bets.
Okay, I use Seroquel fairly regularly. Please talk about risks.
Right. So I use Seroquel in the inpatient very regularly for a short period of time, and I let them know it's a short period of time. So the risk of Seroquel is that it can be abused from a misuse standpoint, and that's unfortunate because there's not, it's not fair that you're going to get punished for your patient's misuse, but the reality is that that can happen. And the misuse can result in excessive sedation. The risks of Seroquel in of itself is the metabolic risk. So it's number 3 in weight gain. So you're going to gain weight with Seroquel. It causes orthostatic hypotension, which could lead to falls in the elderly population and in the very anorexic population. So you're going to have them falling when they get up in the morning. So that's a risk. It's very bad with the QTC prolongation, especially if they're on methadone. So don't use Seroquel and methadone. There's an interaction at the enzymatic level as well. So it can cause QTC prolongation. So you'd have to make sure that they don't have a family history of QT prolongation, that they don't have low magnesium levels, which, nobody's going to really check for magnesium levels. So it is a risk. You might just want to get an EKG if you're going to be using it. But the main risk in the substance using population as opposed to the non-substance using population is that they will misuse it, and then they will have a QTC prolongation, and then you might find them in the hospital. And of course, what they're going to say, and I don't mean to be disparaging of substance users, is like, the doctor gave it to me. I don't know why. I never asked for it.
Okay, what is the place for treatment with benzodiazepines in patients with polysubstance use disorders?
Yeah, so that's a good question. So that's all over the map, right? Meaning that all different providers have different feelings. Now, as far as the official statement, the prudent statement that I should give you is there's very limited use for benzodiazepines in substance using populations. So if they're on methadone, benzodiazepines is not really a good choice at all. And that's because of the drug-drug interaction and the incredible risks of falls that it occurs. The clinical statement, so the official statement is try to avoid benzodiazepines. If you are in court because of benzodiazepines and you're not a psychiatrist with years of experience, it's going to be very hard for you to prove why you did it and why you used it, because there's not a lot for it. The clinical reason is if they failed adequate trials of antidepressants, they have significant anxiety, they're high functioning in life overall, and they seem to have a tendency to misuse medications. Benzodiazepines seem to help with the slowing down of that kind of thing. In other words, it's sort of like a harm reduction coupled with in helping with their impulses and stuff like that. That's if you're using low doses. Try to avoid Xanax as much as possible. Use 2-week prescriptions. Call in. So if they're on Suboxone and benzos, give them a laxative every once in a blue moon so that they can have it done by a pharmacy. If you're a doctor that takes insurance, then go ahead and do oral tests, oral swabs. Anytime that they're positive for anything else, then you can use that benzodiazepine as a motivation tool, saying, look, you know what? You've been positive for cocaine. I'm going to stop your benzodiazepines. So it causes them a contingency management, like, okay, I want to have clean urines or clean oral swabs. If you're a provider that does cash-based and you're doing cups, then like I said, you got to send them out to the lab every once in a while, give them 2 weeks with a refill, occasionally call them in for pill counts. Any type of bad behavior, you have to get them off of benzodiazepine. It's hard to catch because a lot of times they do pretty well, and then you don't know until once in a blue moon that they overtake it. So if you want to have if you want to be comfortable and not worry about it, then don't prescribe it at all.
Okay. And I guess, Robert, we'll have to draw it to a close, and maybe
Okay.
we can answer the other questions and send them.
Yeah, there's quite a few more, so I'll.
Okay, so what Robert will do, he will send the questions to Dr. Masri, and we can get answers, and then we can send it out to everybody.
Okay.
Okay, so I want to thank you for the excellent presentation. Just a reminder, you will be receiving an online evaluation to complete this week, and then also you will receive the evaluation 30 days later again. And also, this program has been approved for continuing education credits by the California State Board of Nursing. So thank you for being here, and I look forward to the other webinars that we will be presenting throughout the year. Have a great evening and have a great week, everyone. Thank you.